Welcome everyone to our ninth meeting in our 2021 virtual meeting series. And tonight we have Dr. Czar Kessler with Massachusetts General / Harvard talking about GI issues with Fabry disease. And so as we normally do, we're going to introduce, I usually open up the conference or the meeting and then introduce Dawn, and Dawn will formally introduce Dr. Czar Kessler. And after she provides her presentation, then we'll have some questions and answers. I'll do a few announcements. We'll do the prize drawing and we'll say goodnight. So we'll start with Dawn. Dawn is my co-host in these meetings and works, gives us a lot of help when we need it. And she has her own enormous full-time job at Emory, as most of you know. And she is a genetic counselor and has a master's degree and a certified genetic counselor. And she is an assistant professor, a clinical researcher, the program leader of the Lysosomal Storage Disease Center, and director of the Genetic Clinical Trial Center at Emory. She also, she's done a tremendous amount of research as either a main author or contributor. Dawn writes children's books about Fabry disease. She's just done so many things. And Dawn is the co-founder of Think Genetic, another organization that you may know about. If you don't know about it, look up Think Genetic online. And she just does so many things, it's hard to keep up with Dawn. And as a service to us as one of those many things, Dawn's gonna introduce Dr. Czar Kessler for our meeting, and we'll go from there. Thank you, Dawn. Thank you, Dawn.
Thank you, Jerry. I think it takes one to know one of doing all sorts of amazing things and working real hard beyond what your normal thing is. So. I'm very excited to introduce Dr. Czar Kessler. She's one of the people I quote the most when we talk about in the clinic room, when we talk about what we know about gastrointestinal symptoms. You see the hand motions, stomach emptying, and rapid intestinal emptying. And all that I learned from her. So Dr. Czar Kessler is the medical director of the Pediatric Gastroenterology program and an instructor at Harvard Medical School. And she has done great work in Fabry disease, in particular, focusing on one of our under-focused on organ system that is so critical to good quality of life, which is the GI system. So I will give it to her to take away.
Great, thank you so much. I'm going to share my screen. Can everyone see this?
Yes.
Yeah, okay, great. So thank you for that introduction. I'm excited to speak with everyone tonight. You may have heard me speak before about some of the topics on GI manifestations in Fabry disease. So tonight I'm going to try to just hone in a little bit more on what our thoughts are behind some of the disease processes of the GI manifestations and some of the treatment options. And I'd be happy to answer questions either during or at the end. So just a little background about the epidemiology of the GI complaints. There's a wide range of percentage of patients who have GI complaints in Fabry disease that's in the literature. So there's a range from 16 to 70%. Most people quote around 50% of patients who have Fabry disease also have GI complaints. There tends to be a sex differentiation between males and females earlier on in the disease course. So younger males tend to have more significant disease than females, particularly related to GI symptoms. But over time, studies have shown that men and women tend to have pretty significant GI symptoms. So they become equal as they get older. In children specifically, the range is also pretty high or large, from 18 to 60% of patients who are children report some GI symptoms, and it can be one of the initial symptoms of Fabry disease. So interestingly, up to 20% of patients say that it's their initial presentation of their symptoms. And as I mentioned before, it is one of the earlier and more severe presentation in boys versus girls. So in terms of the prominent symptoms, The most common that we talk about is abdominal pain. That's typically what patients will complain about the most. It's described in many different ways depending on the patient. So some people say they have severe, sharp stabbing pain. Other people say it's more cramping pain. Some people say it's dull pain. It could be anywhere within kind of the stomach area. So it's not a specific type of pain. The other most common presentation of GI symptoms is diarrhea. So people will say really significant symptoms of diarrhea. So I've had patients who will say they'll have to go to the bathroom 10 to 20 times a day. Others who say it comes and goes. So they'll have 1 or 2 days where they have significant diarrhea, and then the rest of the week they feel fine. Some say it's specifically food intake associated. So whenever they eat, they know they have to be near a bathroom because they'll have to go to the bathroom 10 or 15 minutes later. And others will say it's really specific food intake specific. So like fatty foods will cause symptoms, lactose, things like that. Constipation is also reported more significantly in females than males, not as common as abdominal pain or diarrhea. And it's also interesting to note that in the general population too, females tend to have more constipation than males. So that kind of mirrors that in Fabry disease. People also will say they have nausea, vomiting, early satiety, which means early fullness. You'll take a few bites and then you feel really full afterwards. Body mass index is what we describe as the relationship between your weight and your height. And so you want to kind of have appropriate proportional height to weight. It had been reported earlier that patients with Fabry disease had a lower body mass index, that they were underweight. But more recent studies are showing that they're equal to the general population. And then there's also been reports of severe and rare presentations like perforations of the GI tract, colostomy, which is where you have to have a bag placed, intestinal necrosis, and then fistulas, which are connections between different parts of the GI tract. And the take home that we find a lot is that the GI symptoms significantly impact the quality of life. And so with any of these types of symptoms, patients really report that it impacts on how they can function, both related to work, how patients who have to bring changes of clothes to work, how they participate in social events, how they, younger patients, how they participate in school. And so it's a really important topic to address. And just over here is what we use in the GI clinic when we try to differentiate what type of stool and bowel movements patients have. So in terms of treatment options, which is where I'm going to try to focus on a little bit more today, we have ERT and chaperone therapy, which the goal is to reduce the lipid accumulation, but this is shown to have variable effects on GI symptoms. So a survey that came out in 2019 showed that there was continuing presence of GI symptoms in many patients who are on ERT. And then a recent study that was put out this past year, where they looked at many patients over almost 5 years or more than 5 years of symptoms, found that there was a difference, that fewer classic patients with Fabry had abdominal pain 5 years later, and also fewer patients reported diarrhea 5 years later. And this was statistically significant. But I still want to draw you to the point that even though it was improved, so this is 56% initially, and then 5 years later, 41%, there's still almost half the patients still report that they're having GI complaints. So even though we can say, oh, there has been improvement with our treatment of Fabry disease, there's still something to be said that there's ongoing issues with GI symptoms. So that's to say, up to 1/2 to 2/3 of patients continue to have GI symptoms despite specific Fabry treatment. And the persistence of the GI symptoms, even in the setting of Fabry treatment, underscores the role for understanding the GI symptoms and initiating targeted treatment for the GI symptoms. So that gets to kind of the crux of what I want to talk about today, or what are the GI diseases that might be related to Fabry's disease, and kind of how are they related, and what can we do to try to target and focus the GI therapy. So this is just a moment for us to talk about what we think might be causing some of the GI symptoms. And so it's similar to other organ systems in that we think it might be related to multiple different processes. So we have the inflammation and the immunologic processes, the neuropathy, and then the vasculopathy. The vasculopathy is thought to be related to, similarly in other disease processes, accumulation of the GL3 in the vessels, in the blood vessels, and this can lead to a thickening of the blood vessels and poor flow of blood through the blood vessels. And that can therefore lead to issues with oxygen not reaching the points that they need to, or maybe not targeting some of the nerves. So those nerves can't function as well because they're not receiving the blood that they need to. And then neuropathy is really what we think is a major issue in GI symptoms. And the thought behind that is that these nerves have accumulation of the GL3 within the nerves, and that also maybe the functioning of the nerves themselves is inappropriate, either because of cell signaling or they're not receiving the blood that they need to. And so the autonomic nervous system, which controls a lot of the GI tract and is part of the enteric nervous system, is not functioning appropriately. And that's what we think is causing a lot of the GI symptoms. So this is a picture that was published in a paper a few years ago that I thought was really interesting and can kind of help us understand some of the things that we think is going on. And I'm going to just break it down and then break it down even more into what we see in the GI practice. So these are villi, and villi are little projections that we think of them kind of little fingers that come out in the small bowel. And they are lined by cells of the small bowel, and they help with absorption of nutrients and also release of digestive enzymes, essentially to help with digestion of the food that you eat. And what we think happens is that you get accumulation of the GL3 within these cells and within these tissues, and you get enlarged villi, and the villi don't function as well. So those processes that they typically do with absorption and with digestion of food just don't work as well because these villi aren't functioning as well. We also think maybe there's a change in the microbiome. And that's a hot topic these days, but the microflora, and that's the bacteria that's in the gut, that maybe there's an imbalance between the harmful bacteria that's there and the helpful bacteria. And that maybe in other individuals, there's a greater amount of helpful bacteria, but in Fabry patients, maybe there's a shift in the balance of it and they're more harmful bacteria. And then down here is the picture of the enteric nervous system, which is what I talked about briefly before. And these little star things here are the nerves. And then you have muscles in here too. And then we see all these dots of the GL3 accumulation. So we think that they accumulate both within the nerves. And so the nerves themselves aren't functioning as well. The projections from one nerve to another aren't functioning well. So the communication between them isn't going as well. And then we also have GL3 accumulation within the muscles themselves that we need for contractions in the GI tract. And those muscles won't function as well with increased accumulation. So it's kind of multiple different factors that we think are playing a role. So before I kind of break it down, I wanted to just make sure that we all know what we're talking about when I talk about the GI tract. So when you eat, you chew in your mouth and then you swallow and it goes into the esophagus, which we call the esophagus, and it's essentially the feeding tube. At the end of the esophagus is something called a sphincter, and that's a tight muscle that stays tight until you swallow, and then it relaxes to let the food into the stomach. In the stomach, you have contractions, and all the food that you've eaten starts to get digested and broken down. So it can be really, really kind of sludge-like. So it can pass through another sphincter, which is a tight muscle, to go into the small bowel. Once it gets into the small bowel, it starts to be digested and absorbed. And this is not a great picture, but the small bowel is very, very, very long, much longer than this picture shows. And this is where the majority of absorption happens until essentially feces are brought into the large colon and the large intestines, which is called the colon. And this is where water is then taken back into the body and it's formed as feces until you're ready to defecate. This here is the liver and the gallbladder. I'm not going to focus on that today. And also the pancreas, which releases enzymes, that I'm also not going to focus on that specifically today. So I do want to spend a minute talking about motility, because we think that's a major focus of why things aren't working that well in the GI tract. So I'm just going to break it down into the GI areas that I just mentioned and what happens in terms of motility. So we have the mouth and the esophagus, and this is where you have the chewing in the mouth, you swallow, and then you have something called peristalsis, which is an important concept to think about, and we think about a lot with the GI tract. So what peristalsis is really just forward contractions moving things along. So I have this picture down here where you get a contraction behind the food, and ahead of it, you get a distension or dilation of the GI tract. So essentially, when you think about it, you get contractions, that food is pushed along, and then you get dilation to kind of accept the food that's coming along. And this is kind of moving along in a forward fashion. And here it just says, imagine pinching a tube and then sliding your finger along the tube, and that's how food is passed along the GI tract. And we think of peristalsis in healthy individuals as kind of how things move from one end of the GI tract to the other. And it happens along the GI tract. So in the stomach, you have what I talked about before, kind of that movement, those contractions, we call them churning, to kind of break down the food. And then you have the peristalsis, which moves things from the front of the stomach all the way through to the small intestines and empties into the small intestines. In the small intestines, you have contractions, which are just these kind of up and down contractions to just mix everything together. But then you also have this peristalsis, which is movement of things in a forward motion until it reaches the large intestines, which is where you get a mass movement, which is essentially peristalsis, but a really great big one that moves this whole amount of feces all the way towards the end when you're able to defecate. And the sphincters that I mentioned are things that help us regulate how things are moved through. So they're really tight muscles that will relax when things are ready to move through. So now I just want to spend the majority of the rest of the time just talking about different disease processes that we think are contributing to the GI symptoms in Fabry patients and why we think that might be happening. So the first one I want to start with is at the top of the GI tract, and that's related to the esophagus and the stomach, and that's gastroesophageal reflux disease. Many of you may have heard of it just as reflux, that I have really bad reflux, and that's essentially, if you look at this picture, here we go. We have this picture here. This is your stomach, and it has gastric fluid in it. And that's just made by your body regularly. You can make up to 4 liters a day. You have a lot of gastric content here. And in your gastric content is a lot of acid that's released in the stomach. The stomach sees a lot of acid. That's normal for the stomach. It actually has protection along the mucosa to protect it from the acid, but the esophagus itself does not have that protection. So what can sometimes happen is the sphincter here relaxes or isn't strong enough. And so you have this contents of these acids going up into the esophagus. And what happens then is that acid then burns the esophagus, or the mucosa there isn't used to seeing acid, so it feels really uncomfortable. And so what you can get then is what we call heartburn a lot, or regurgitation is when this acid comes up. People will say they get chest pain with reflux. And so you can get all these different types of symptoms all the way up in your chest. And that's from acid reflux happening. And the question is, why do we think this happens more so in Fabry patients than in other patients? We don't really know, but one of the thoughts behind it is maybe the sphincter at the bottom that I've talked about a couple times is weak, and that the tone itself is not that strong. And so maybe because of the GL3 accumulation or the muscle itself or the nerves there, it's not functioning appropriately, or it's relaxing more often. And so what we're getting is more of this reflux coming up than you would see in other individuals. Or it could also be related to maybe these contractions, or the peristalsis is not as efficient in patients with Fabry disease. So it's not moving things along as well. So even when we get reflux in a healthy individual, you can get normal reflux, but your esophagus will then contract to move it back into the stomach. But perhaps in Fabry patients, this contraction doesn't work as well. And so when you do get reflux up, it kind of sits there and burns even more. So the acidic contents will stay in the esophagus for a longer period of time. So those are all theories behind it. I just saw, so we don't know specifically how common it is in Fabry patients. That's what we're working on now. Jerry just asked how common we see that. We think maybe some of the abdominal pain that patients describe is related to reflux disease. And so in our intake, in terms of what's taken in typical doctors' offices, or what we collect in terms of the registry, we don't specifically say where is the pain located. And that can help us differentiate where we think, if it's related to reflux disease versus other types of pain that we'll talk about later. For a diagnosis, you can do it based on symptoms, particularly where it's located. So it's pain that's usually described more as a burning pain, and that can be higher up. Or you can do an analysis of it. And these are just pictures of tests that your doctor can do for you to assess if you have more symptoms of reflux disease. And this is where you can put a tube in that has a sensor at the end that checks to see how much reflux you have over a 24-hour period. And this picture here just shows a little capsule that can be placed in the esophagus and stays there for 48 hours, and then it just drops off and you can pass it in your feces, and that also can measure how much reflux you have. Some of the treatment options, there are 3 different types of things that we use. One is, I'll start at the bottom, are antacids, and those are what you may have heard of in terms of brand names are things like Tums, Maalox, Mylanta. Those are things that neutralize the acid. So if you're having an attack of really bad pain that we think is related to reflux disease, we think, okay, well, maybe if we can neutralize that acid, then it can make us feel better in that period of time. And so those medications are used what we call in more acute periods. If we think, okay, there's something that's happening right now, I'm in a lot of pain, let me see if this helps me. The histamine blockers are antihistamines, and those are used to decrease the amount of acid that's released into the stomach. Those are a little more fast acting than the proton pump inhibitors, but they still don't act as quickly as the antacids. I have found with patients, though, that they start to lose their effect over time. So people say they work initially well, but then they lose their effect. And then proton pump inhibitors are things you may have heard of as brand names. They're things like Prevacid or Prilosec or Nexium. And what these do are these also reduce acid flow into the stomach. So even if you have reflux, it doesn't burn as much or it's not as painful. But these are not to be used as needed. They are more long-term treatments because they don't work as quickly. And so if you are using these, you shouldn't take them, oh, I'm having pain, I'll try to take it. It should be more on a daily basis that it's used. So that's what we think might be happening in some of the esophagus. Moving down a little bit, we get to the stomach, which is a nice picture here. So in healthy stomachs, as I mentioned before, you get the grinding of the food, it breaks it all up, and then you get the movement of the food. So it starts over here and it gets moved all the way through the stomach to the beginning of the small intestines. This is another sphincter here that needs to let the food through to get into the small intestines. If the sphincter here, if the food itself is not broken down enough, then it won't be able to pass through the sphincter. So the sphincter is very strict about what it lets through. And unless it's really broken down food, it won't let anything through. So that gets to the issue with the stomach. If the stomach isn't contracting well, or moving things around to digest it, or moving things from one end to the other, then you won't get things moving to the small intestines. And that's where we have situations called gastroparesis, which is poor movement of the stomach. And we do see that in Fabry patients. Why would we have this in Fabry patients? Because of the things I've been mentioning, that we think there's poor motility possibly, and that the stomach itself, because of the issue with the nerves not functioning and the muscles possibly not functioning or not receiving appropriate blood flow, that things are not moving through the stomach in the way that we'd like them to be. O'Brien put out a paper, this is one of the first ones that was put out many, maybe 30 or 40 years ago, where he looked at 7 patients with GI symptoms and found that 5 of them actually had a delay in gastric emptying. So a significant number of Fabry patients do have a delay in gastric emptying. And then also there is another study that looked at the actual cells under the microscope and found that patients who have the delay in gastric emptying actually had an increase of the GL3 in the nerve cells related to this autonomic nervous system I've been talking about. So that this all seems to make sense, that when you have this accumulation in the nerves in the stomach, those muscles might not be working as well, the nerves might not be working as well, and therefore you get a delay in how the stomach is functioning. And the symptoms that we typically see with gastroparesis are nausea, early fullness, so you take a few bites and you feel full, you can get vomiting, or also pain that we've talked about. In terms of a diagnosis, it's done by a gastric emptying scan. And so that's where you eat a standardized meal, which I always find is interesting. The standardized meal is an egg sandwich, which I think is a little odd because people who don't feel well, who might have nausea or not want to eat that much, are probably not going to want to eat eggs. But that's the protocol that we have. And so people who want to get this test done will eat an egg sandwich that's radio labeled, so we can see it when we take pictures. And so this is it immediately. You can see it in the stomach, and then you can see how it flows through into the small intestines. And here even more has flown, gone through the stomach into the small intestines. And so that helps us understand how quickly things move through. In terms of treatment options for this, we treat things with pro-motility agents, and that's exactly what they are. They help with motility or movement of the gut. So one of them is something called erythromycin, and that's an antibiotic actually that's used, but it's not used at antibiotic dosing. It's used at a much lower dose. And at these lower doses, it helps to target the receptors that help to move things along. If it's used at antibiotic dosings, it can possibly still work, but you get a lot of the same side effects as antibiotics. So you can get more stomach upset or diarrhea. And so we like to use it at these lower doses where we think it's more effective. There's another medication called Metaclopramide, which is also, the brand name is Reglan. And that also can help with moving things along, but may have more side effects related to movement of the body. So now moving on from the stomach, we get into the small intestines. So one of the popular diagnoses these days is something called small intestinal bacterial overgrowth, or SIBO. If you've looked up some of your symptoms, you may have seen things related to this. It occurs when there's an abnormal increase in the bacterial population in the small intestines. And it's particularly bacteria that typically aren't found in this part of the digestive tract. So typically it's bacteria that we see more commonly in the colon, we see in the small intestines. We think there might be something like either surgery or disease that slows the passage of things through the small intestines, both food and waste products. So it creates a breeding ground for this bacteria to then grow and accumulate and get to high amounts. This excess bacteria then can cause the symptoms. And they have found that up to 90% of cases of SIBO are related to some issue with motility. The symptoms are similar to other symptoms of nausea, abdominal pain, or fullness, but also in SIBO, you can see a lot of bloating and gas because the bacteria that's there, the excess bacteria, can digest the food and release more gas. And also patients may complain of diarrhea. So in Fabry disease, why do we think we have it here? And it all makes sense in that we know there's the dysmotility of the gut because of this neuropathy and the vasculopathy. And so these small bowel microbial changes are likely due to stasis, which is kind of things not moving well, and a dysmotility, which leads us to have increased bacteria. So they did a study back in July of 2015 where they took 12 patients with Fabry disease. None of them were on enzyme replacement therapy, and 12 controls. And they found that starting off, the patients with Fabry disease did have significantly increased prevalence of GI symptoms compared to controls, but they also found that 6 out of 12 of them had small intestinal bacterial overgrowth. And so, you know, it's hard to say specifically, is it because of Fabry disease or what may have caused it? And if the SIBO is what's actually causing the GI symptoms. But I think it is something to note because it's important for us to think about how are ways that we can target some of these GI symptoms and what might be causing them. And only 1 out of 12 of the control patients had SIBO. So if you're talking with your doctor and you're interested in discussing this, the way they would test for it is a breath test. So what you do is you drink a carbohydrate. There are different types. There's something lactulose or glucose. And the mechanism is that they think that this, whatever carbohydrate you drink, is broken down by the bacteria that's in the small intestines that typically isn't there. And it produces a gas that you absorb and actually release into your breath, into the lungs, and you breathe it out. So we can check your breath after you ingest this to see if this gas has been released. And then if it's higher than we would expect, then we would say you have SIBO. It is somewhat controversial in terms of the testing and the response to treatment, because a lot of times we find that patients who test positive don't always have the best response to treatment. Those who respond to treatment aren't always the ones who have positive tests, but it still is the gold standard of how we think about testing for SIBO. In terms of treatment options, there is the first line treatment is something called rifaximin. It's a newer antibiotic. It targets the bacteria in the gut, and it's taken 3 times a day for a 14-day course. Other antibiotics or a combination of antibiotics are also available. And then there's a lot of controversy about repeating courses of therapy because patients may respond to treatment and then a few months later not feel as well. And so the question is, do you repeat the treatment or do you do repeat testing to see if maybe the bacteria reaccumulated? And that's something that we discuss a lot in our GI practice. Then finally moving down into the small and large bowel, which is where we can talk about some of the other important symptoms, which are diarrhea and abdominal pain. So for the diarrhea, there are various reasons that we think that it happens, but it clearly is a very common symptom in Fabry patients. So we think it might be related to spastic contractions and discoordination of neurological activity. And that goes back to what we were talking about, this peristalsis, that we might not have this forward flow of things that we typically see, but maybe things are contracting at different points and not relaxing at the right time, and that the neurological activity is not kind of coordinated together. The communication between the nerves and the muscles might not be appropriate. And then also this question of the villi accumulation I talked about before with the projections in the small bowel, is that maybe those villi aren't absorbing things as well. And because of this malabsorption, then you get things like diarrhea because your digestion is not working appropriately. And then we think about also the abdominal pain that we think might be related to the small and large bowel. There could be a component of ischemia because that's a lack of blood flow because of the vessels that are really large and big and not letting the blood flow through as easily. And then we also think it's related to, similarly to the other organ systems, is a neuropathy, that these nerves themselves, because they're damaged by the GL3, that they're not sensing things appropriately, or they might be hypersensitive or feeling things in an inappropriate manner. And this is just a picture of a radiograph of the colon, and this is contrast through it, and you can see contrast isn't filling it because we think maybe there's spasms of the colon at different points. And I just wanted to spend a minute just to briefly mention irritable bowel syndrome diarrhea type. Irritable bowel syndrome is a diagnosis of exclusion, meaning that you do a lot of workup, everything's normal, but you have symptoms similar to Fabry patients of diarrhea and then also abdominal discomfort. And a lot of times we think of them in the similar realm of presentation, and that maybe irritable bowel syndrome is similar to Fabry in that there's a neuropathy or some damage to the nerves, and that's what's causing these symptoms. And so a lot of times we think about similar treatment options for patients with irritable bowel syndrome diarrhea type. And interestingly enough, one of the treatments for IBS is rifaximin, which I mentioned earlier for SIBO. And the thought behind that is that it targets some of the bacteria that might also be affecting patients with irritable bowel syndrome and can help them with some of those symptoms. So if you're interested in evaluating for diarrhea, the SMART pill, I've mentioned this before, is a motility study. It's where you swallow this lovely pill here. It's much smaller than it looks here. And it gives you a 5-day assessment of the whole gut transit. So it can tell you how fast things are moving through the stomach, through the small intestines and the large intestines. And you can see if it's really fast or really slow. It also tells you the pH levels and the contractility, which could be interesting in Fabry patients to see how things are actually contracting. There are various options for treatment. So there's loperamide, which you may have heard of, which is the brand name of Imodium. That's used frequently with diarrhea. I have a lot of patients who use it. It's kind of used as needed, and I do find that patients do respond fairly well to it. Lomotil is another type of medication that's used for diarrhea. And then down here is one that I use a lot in Fabry patients and in a lot of my IBS patients, and that's tricyclic antidepressants. And those are in the class that you may have heard of, amitriptyline or nortriptyline. It is frequently used for neuropathic pain. So it's used in other organ systems. A lot of times it's probably, you may be on it for other pain symptoms or other people you know. It's used a lot in migraines frequently or fibromyalgia. And it's thought to target some of those nerves. So it's not used as an antidepressant anymore, although it had been made as that, but it's used to target kind of pain syndromes. I love to use it particularly with my GI patients and patients with Fabry because of this overlap with abdominal pain and diarrhea. One of the beneficial side effects of it is that it can slow things down, which we love with patients who have diarrhea. So you can get the added benefit of causing constipation or slowing things down in addition to targeting some of those pain. And so I will frequently put patients on one of these medications. And then I want to just spend a minute talking about microbial changes. And I think that's an important thing to address because I get a lot of questions about it. And it's a pretty popular topic these days. So are there changes in the microbiome of the colon is a big question in the general population and particularly in patients with Fabry disease. So a study was put out a couple of years ago that analyzed the microbiome in the colon of patients with Fabry. And they found that GB3 did modify the biology of the gut bacteria so that it did change the actual bacteria that's there. And they think this is related to the GB3 there. So it altered the composition of the microbiome, increasing bacteria like Bacteroides fragilis, which is a common bacteria that we see in the gut. And this produces a change in kind of the biofilms there. It also modifies the formation of short chain fatty acids, which are produced in the gut. So it decreases the concentration of it that's made by the bacteria in the gut. This butyrate, which is one of the short chain fatty acids, is thought to support immune system function and protects against certain diseases. So the question is, because if there's a decrease in this, is this related to some of the symptoms that Fabry patients may be having? But I think the big thing here is to just note that this is just in a kind of a petri dish. They kind of looked at things under the microscope, but this is not in real life. And so we don't know how to take this information that we can look at under a microscope or that we can test for in terms of bacteria and translate that into our understanding of what to do for Fabry disease. So it's really unknown what to do about these microbial changes. A big question that I get a lot is probiotics. And that is probably many of you have heard about probiotics. They're called quote unquote friendly bacteria or good bacteria in the gut. They live in our body and they help it work well. They're thought to improve the intestinal barrier function, so kind of keeping things within the GI tract, not letting it leak out into the rest of the body. They're thought to help modulate the immune system and to maybe modulate pain receptors, so kind of help us with pain and immune system. But I think the important thing to note is probiotics get into your body on their own. So you can still get benefits from probiotics without actually doing anything or taking extra pills. So a lot of times they're in dairy products, so yogurts and things like that. And one of the things I think is really interesting is that for babies, their microbiome is related a lot to what they're exposed to after birth. And so it's not that they eat anything or take anything, it's just exposures to what's around them. And that's similarly to adults, you can get probiotics, or you can get this bacteria in your body without necessarily ingesting probiotics. Are there any known benefits to probiotics in the GI tract? There are some. In inflammatory processes, studies have shown, so like inflammatory bowel disease, which is Crohn's disease, or ulcerative colitis, it's been shown to be beneficial. With infectious diarrhea, so if you have an infection like a viral gastroenteritis, it can help with that. But it really hasn't been shown to be beneficial in many studies that looked at constipation or irritable bowel syndrome. And at this point, there's really no known data in Fabry disease to support the use of probiotics. So should you take it? Things to consider is it's not regulated. It's not regulated by the FDA. So we're not really sure what's in each probiotic. It's kind of based on the company and what they put in it. It's made up of all different types of bacteria, millions and millions of different bacteria, and each probiotic is different in terms of what bacteria they're put in. And so it makes it difficult to know which one to use or which one to try. They are minimal risks, so I don't have a problem with patients taking it, but it is a higher risk in patients with a weakened immune system. Not that I would say Fabry patients are significantly immunocompromised, but if someone is immunocompromised, it is something to consider because it is introducing extra bacteria into the body. And so it's something to think about. And I think when I tell patients, I say, I don't have a problem with patients trying it. I don't think the risk is significant. So I think it's perfectly fine to try. I don't have data to encourage you to try it because nothing supports it at this point. But I think what I say is try it for a month or two. If you don't notice a difference, it's not worth staying on for a year or two. It's expensive and it's not going to start to suddenly help you if it hasn't initially. And I think the important take-home message is, even though there's good proof that they can help the body, the probiotics, there isn't good proof that taking the actual pills does anything different. And so we're really at the point of trying to figure out what our understanding of the microbiome is in relation to what we can actually do about it in the human setting. So we're still kind of looking at things under the microscope and studying it and don't know exactly how to translate that into our daily lives. And so that's kind of what I wanted to talk about today. I hopefully will have another chance to talk with you in the future about nutrition and dietary considerations, because there's a lot that I know people want to hear about too, related to things to eat. And so things I'll hopefully talk about at that point would be related to lactose intolerance and eating of dairy products, the FODMAP diet, which is a popular diet in irritable bowel syndrome, but also frequently used with patients who have bloating or gas or abdominal pain. Gluten intolerance, which is a popular diet now, gluten-free. And then spend a little time talking about this concept of malabsorption and how we can maybe change our diet or think about that in relation also to pancreatic insufficiency in absorption of fats. And then just briefly at the end, I did want to mention we are finishing up a recruitment for this study for GI symptoms. So if you know anyone who is treatment naive or has been on treatment for less than 6 months and has any GI symptoms, we're doing a study looking at the GI presentation. And so we would do the SMART pill. We also take a biopsy to look at it under the microscope, and it helps us really understand the presentation. It's at Mass General Hospital, and we would support travel if you know anyone. And so these are just, if you want to contact our research coordinator, here's the email address and the phone number. And I would be happy to take any questions now.
Yes, Doctor.
I love the coming attractions.
Two issues. My GI issue, normally I have pains just below my ribs. So
Yep.
all I do to get rid of that pain is to ball up my fist and lay on it.
Okay.
But sometimes that doesn't work. I don't know what the pains are. And it's not after I ate or anything like that.
And what have you tried?
Oh, I've tried antacids. I've tried, Maalox, Rolaids, Tums. None of that seems to work. I lay on my fist on the floor
Yep.
for a while, and it seems to
The
relieve.
pressure, you think? The pressure
Correct.
helps it? And have you used like a long-term, like Nexium or Prevacid?
No.
So the one thing because right up between your ribs is right where the stomach is. And so that's called the epigastric area. And the Tums and those things might not work as well because they're only used to neutralize whatever acid is there. So if the acid is already there and burning the esophagus, then it might not do anything at that point. But if you can take something on a daily basis to prevent the acid from being there, then that could possibly be something that could, over a month or two, maybe decrease the pain that's there because it's preventing the acid from.
It doesn't happen that often. I'd say maybe, if anything, once or twice every 6 weeks. I'm already on 12 pills a day.
Okay.
So adding another pill is not really what I'd like to do.
No, I get that. But it certainly could be related to an acid. It sounds like it might be the location of it. Sounds like it could be, that it could be related. And sometimes that's related to sometimes a food you ate, although it might not be food related, but your stomach you could get a large, what we call like bolus, a large amount of gastric contents that goes up into the esophagus that can kind of burn it. And if it sits there, and maybe the pressure kind of gets it back down.
Okay, I can understand that.
Think about, yeah.
My other issue is related to my bowels.
Yeah.
I will have a solid, like a number 3 on your list. And then all of a sudden it jumps, the next bowel movement will be a number 6.
Yeah. Yeah. And I hear you. I think that's one of the most difficult things that I have found with my patients, because it also makes it really difficult since this is more of a fluctuating one, right? And so it's not, if it was just diarrhea, it makes it easier in some ways, because we could say, okay, let's just treat for the diarrhea and then we're good all the time. But the concern is if we treat for your diarrhea, then we make your ones that are type 3 more type 1 too, and we don't want to have that situation too. Have you taken anything for the diarrhea?
No.
Have you tried Imodium?
When the diarrhea gets number 7,
Yeah.
yes, I would have to.
Yeah.
But that happens once in a while. I'll have a 3 in the morning, a 6 later in the afternoon, and then later on a 7.
Yeah, it's interesting also because your body, the colon actually sleeps at night. And so what might be is you kind of wake up in the morning, you have your stool there and it kind of comes out. And then when it's more active during the day, maybe it's having many more of those contractions that we were talking about, or kind of the spastic ones. And that could have leading to more diarrhea kind of as the day progresses. But, I think the big question is if you want to try medication for it, or if it's something that you manage and it's not as much of an issue. Because there's certainly a lot of medications we can consider. Dietary wise, there are also some things to think about that I'll hopefully talk about next time, in terms of maybe changing some diet things around that might be triggers.
Okay, well, thank you very much.
No problem.
We have a couple questions in the chat. You can read them there, or I can read them out to you, whatever makes you happy.
It says, should I read them out loud? Or I guess everyone can. Okay. So it has not been documented that there's this is about C. diff, that there's an increased risk of C. diff. It's an interesting thought, going back to the whole question of the change in the microbiome, and is there a difference in the bacteria there? And is that putting you at increased risk for C. diff? But there's just not enough data to say if that's true or not true. There are many people who get C. diff after antibiotics. And so it's hard to say, is that unfortunately, is that just what happened? Or is it because of kind of the underlying kind of composition of the microbiome that puts her at higher risk? That being said, with infectious processes, probiotics are certainly things that we think about. So there could certainly be a relationship between her microbiome and maybe at an increased risk. Okay. It's an interesting, so the question is about heat intolerance and increase in diarrhea. I have not heard that specifically. Again, our data is very, very limited. So everything is mostly anecdotal or based on kind of the registry data. And so in terms of the data that we have related to that, I don't know anything. But it is, it's an interesting concept to think about, because if you think maybe a heat intolerance leads to kind of a pain episode or an episode of the nerves kind of firing, triggered to be more hypersensitive or to be firing in more of an active state. Could that then translate into the GI tract also and being in a hyperactive state to pass things along? I think it's an interesting idea. I don't know enough to comment on it. I haven't actually heard that frequently. But one of my interests is kind of trying to correlate the severity of GI symptoms with the severity of other kind of disease processes that Fabry patients have. And so it's an interesting thing to think about, time correlation, which I haven't looked into.
I wonder if you could comment, I know you can't generalize, but what has been the treatment that you've seen for GI symptoms, or a specific GI symptom you've treated that seems to make the biggest impact in life, the quality of life?
So it's a good question. I think the biggest difference, I think, is the treatment for the abdominal pain and the diarrhea. I actually think, I don't know if others agree, from what I've heard, diarrhea seems to be the most kind of debilitating. Pain can be pretty severe, but patients who have really bad diarrhea, it really can be impactful on people's functioning. And so I do find targeting those two to be the most beneficial. And that I have found the most success with something like a tricyclic antidepressant, like amitriptyline, nortriptyline. There are other medications that I know are used in Fabry disease for pain episodes, so like gabapentin or things like that. The reason we don't love them as much is because we call them GI neutral, if you will. So they don't really have much effect on the GI tract, which is good in patients who are constipated. But a majority of our patients, they have diarrhea. So I really do like that side effect of not only targeting some of the pain that's going on in the GI tract, but also targeting the diarrhea with only one medication. And so that's where I would say kind of biggest bang for your buck would be if those are the symptoms.
Thanks. Yeah, that makes a lot of sense. Lene has a question. How many Fabry patients are lactose intolerant?
These are good questions. So again, the data-wise, we're really lacking because it's all just based on patients. My information is based on patients that I see. The data that we have kind of published is mostly based on registry data. And information, as you guys probably know, information collected from the registry is very simplified in the sense that it's related to abdominal pain, diarrhea, but we don't specifically ask the questions, oh, how do you feel when you have dairy or lactose or things like that. And so I would say in terms of patients that I see, not that high of a percentage, but it is something, just to get into a little science behind it, lactase is the enzyme that breaks down lactose, and lactase is released in those villi that I was talking about. And so if those villi are damaged or they're not functioning appropriately, you could think maybe that enzyme isn't being released and the lactose isn't therefore being absorbed or broken down appropriately. So it makes sense in terms of a mechanism of why patients with Fabry may also have issues with lactose intolerance. Yeah, so that is a good question. How does the gallbladder play a role? And that I'm hopefully going to try to focus on a little bit more next time. The gallbladder and the pancreas is actually, the pancreas is one area that I think there's some questions more about. So the pancreas really helps with fat digestion, as does the gallbladder, in terms of what's released, the bile that's released, and then the pancreatic enzymes. And so there's a question, and there's a study that I'll talk about next time related to pancreatic insufficiency. And maybe the enzymes aren't being released or being made appropriately. And so that leads to issues with fat absorption. I'd be curious, when you say that you have pain after eating, have you noticed if there's any difference with food, specific food? Is it fattier foods are worse, or is it just any type of food? is something to think about. But yeah, it's definitely, gallbladder specifically is related to fat. So it's something that I'll hopefully address next time. Yeah, so that.
I have definitely heard patients say that they avoid greasy food because it can make the diarrhea much worse when they have the greasy or spicy.
Yeah, so that's what, so they said dietary options next time. That's my plan for next time, is kind of dietary things. I just couldn't get everything in one quick lecture. But yeah, I think there's a lot to talk about with dietary options, different dietary things to think about. You know, the lactose, the gluten is a big one, are big things that people are kind of thinking about these days. Fat is certainly one of the areas. So greasy foods are essentially fatty foods. And so I think that related to the pancreatic functioning, the pancreas is controlled by the autonomic nervous system. So there's a lot of thought behind if that's not functioning appropriately. And maybe that's why greasy and fatty foods are affected, because you're not absorbing and digesting the fat, and therefore it's not being absorbed and leads to diarrhea or pain. Okay. Spicy fatty foods. Yeah. So spicy, not as much as related to the gallbladder. Spicy is thought to be more related to kind of a gastritis, which is the acid in the stomach. And so sometimes that can irritate the stomach more as opposed to the gallbladder. But that, you know, it could be a combination of the two, honestly. But when we think of spicy foods irritating things, we think a lot of times about the acidity of the stomach and how that can kind of, you know, if you have really, really spicy foods, which I don't eat, but they're peppers that people eat that can actually burn the stomach. Yeah. Any other questions? But yeah, I'm hoping to next time really focus on dietary, because I do think that's been a lot of people have questions about that, and I think there's a lot to discuss at that point.
Sure.
Well,
There was one question, which was, for your study, is it treatment naive to enzyme replacement therapy or treatment naive for gastrointestinal treatment?
Oh, sorry, enzyme replacement therapy. Yeah.
And then, Jerry, have we already picked down a time when Dr. Zar-Kessler is going to speak on the dietary options, the nutrition?
yes. So we've got nutrition on the schedule, nutrition, dietary, whatever you want to call it, on the schedule, or as a topic. We just need to arrange the date and time. So we'll work on that.
Awesome, thanks.
Perfect.
All right, any other questions? And then I can do our drawing.
Let's do the announcements first.
Yep, go ahead.
Yep. So if that's all the questions, Dr. Zar-Kessler, thank you very much. That was a great presentation. And thank you, Dawn, for helping out with the questions and answers. And let me share my screen. One moment. As soon as I find what I'm looking for. There we go. All right, so each time we do a presentation, we do a few announcements. And the first slide that I have is about what industry is doing. And you can go, this whole presentation is recorded. So you can go back to the recording and get details for any of this. And you don't have to write anything down or remember anything, but each industry company gave us information about what they want to ensure that you're aware of. And Scientific Enzyme and Amicus both have their websites where you can get resources. And Amicus, I believe, is working on a revision to their site, which we may see soon. Chiesi has information on their Rethink website. And of course, we just put out something about next steps on their potential approval. AvroBio, Sangamo, 40MT are all currently in clinical trials. So you can get contact information from here on how to start that process, or if you want to learn more about those clinical trials. Idorsia and also Freeline has just, we've just added them to the slide. So now we're seeing there, and I spoke to Freeline today, in fact, and so we're seeing more information about their phase 1/2 trial starting. And then Idorsia, who I skipped because they are a little different. They're not recruiting patients anymore, but they're going through the process of seeking approval. And so Idorsia is, I think most of you know, a substrate reduction therapy. So that's a little bit different. So that's what's going on in industry. And this is just a snapshot that you can go back to and look at in the recording, or if you go to the probably, if I go to my next slide, we put this on the website where if you go to the top menu bar, go all the way across and you'll see pharma info, and you can click on that and there's a grid square for each of the pharma industry companies, and you can, excuse me, if you select the read more button in each block, you can see the resources that the industry companies provide, all sorts of different types of brochures, PDFs, websites, resources that you can access. So you can look at that for a reference also. And then there are also a clinic tab, which there isn't much in there right now, but there's a couple of things. And then there's a support organization tab, and support organization tab has, of course, a few blocks from us and some other resources that you can get from the financial assistance from the financial assistance programs down here, and some other resources. So you can go to that to access resources about other organizations and things you can where you can get information. The next slide is we have a lot of calendars still available. We'll send you a calendar if you've participated in this meeting and don't already have one, but pass that along for your family and friends if they would like a educational symptoms calendar. And for the schedule, you go back to where you're registered for this one. You'll see as we disable the current registration link, we'll enable the next one. So you'll see, it looked like an old, I put an old one up there. Anyway, so you'll see the next presentation that we're going to provide and the link to register. And if you go to the archives and recordings tab across the top, you can access the recording for all of the presentations that we've done so far. And the last slide is a double dose of Dr. Czar Kessler's study. I didn't know she was going to have it. I should have imagined she did, but you can get that information again on your last slide. And now that this is all fresh in your mind, we'll put it on our Facebook page and send it out in our next newsletter to get her some help to continue getting people to participate in this study to make it as valuable as she can. With that, I think that's all I have. I'm going to stop sharing my screen. And Dawn is going to ask you, Dawn.
So the thing is, the gastrointestinal symptoms, there's so many exciting words that we could have for our word of the day, but I'm going to go classy and we're just going to go GI. So if you're on here and you are a primary participant, go ahead and put GI in the comments, and then Brenda's going to draw for a prize. So just put GI in there, exactly.
GI in the chat box.
GI in the chat box. And we'll just wait a little bit for everybody to get their information in, and then for Brenda to random number generate, and then we'll announce the winner.
Yeah, so we're continuing to talk for a moment. Brenda or Brittany, maybe type Brenda, they're probably both doing it. We assign you a number when you put GI in the chat box, and then they put it into a random number generator, and it gives us the winner by your number. And then Brenda or Brittany will tell us who the winner is, and you'll get a $100 Amazon gift card electronically in the next day or two. So always a little bonus. So what did I just say? I saw something in the tech. Oh, that probably didn't come from Brenda though. Someone's wishful thinking.
They're fast, but they can't be that fast. I know it will come. So I just want to thank Dr. Czar Kessler again for a great talk. It was just pitched such a nice level, and really gave a lot of information for everybody, myself included. I still have notes down here too.
Oh, I see. Nicole wants to make sure her answer got in the chat box. So Brenda, if you could check that.
Yes, I see your name in there, Nicole.
Okay. And so while Brenda's still working on that, I'll give my usual update. I just had, I think, my 13th heart biopsy, and after my heart transplant, and no rejection. They're still fooling with my meds a little bit, but that's great news for me. So I'm down to 20 pills a day since my heart transplant, from about 40, I think. And things are going very well. I'm feeling very good and getting healthier all the time. So that's my big news.
That's wonderful news, Jerry. I would also do a public service announcement, since it's GI Day, that everybody should get a colonoscopy beginning now at age 45, because if they find, they take them out. And just because you have Fabry doesn't mean you're immune to colon polyps. So all sorts of exciting things.
Oh, geez.
Speaking of exciting, we have a winner. Do you want to say, Jerry?
Oh, I was just going to say that was you, that you're getting a colonoscopy just did.
Oh, I did, but everybody else should get one too.
I think I read that on Facebook too.
Fun for everyone. All right. The winner is Carol Treadwell. So congratulations, Carol. You're going to get
Carol,
an FDF.
and we will send you an Amazon gift card by email. And thank you to everyone for attending. This was it had a little bit of a bad start, but it turned out okay. And thank you again, Dr. Kessler and Dawn, and we'll see you all next time.
Thanks, Jerry. Thanks, everybody. Thanks, Brenda.